Hi everyone, my name is Wanying. I'm coming from the University of Alberta in Canada. It's really a great honor for me to be here, to be in such a beautiful country, beautiful city, to share the work of our lab with all of you guys. So today, my presentation title is the prevalence and risk factors of depression, anxiety, and poor well-being at psychiatric hospital discharge. So, as most of us already knew, the transition from the mental health inpatient treatment to the community care is often a narrow period where people can experience additional risk and anxiety. Therefore, we believe an in-depth understanding of the mental health conditions of patients at discharge is crucial and instructive for recovery research in the mental health and psychiatry field. The Text for Support program we conducted was developed based on the knowledge of RCT conducted in Ireland and Alberta. The program is also based on the knowledge gained from the highly successful award-winning Text for Mood program in Alberta's North Lawn. To our knowledge, this is the first large-scale clinical trial to assess the impact of the daily supportive text message program with and without the peer support for individuals discharged from the mental health psychiatric care department. The effectiveness of supportive text message and peer support have been demonstrated in several of our previous studies, and some of the studies including the RCTs. I listed some of them here. So in one of our RCT trials that aimed to investigate the effectiveness of peer support and supportive text messaging program on the recovery of overall 65 participants from the acute psychiatric care, the higher recovery assessment scale score were found for the peer support plus text message condition, compared with the text message only and treatment as Eurogroup. Indicated that peer support plus supportive text messaging result in significant recovery compared with the other interventions. Another study intended to evaluate the effectiveness of peer support and text messaging in reducing psychological distress. Discharged patients from patients' care for about, in total, 63 of them. The results show that the combination use of peer support and supportive text messaging is a powerful intervention with positive clinical outcomes for acute care inpatients. Our group has conducted several other studies demonstrating the effectiveness of both supportive text messaging and peer support on patients' mental health. If any of you are interested, I'm very happy to share and discuss after this presentation. So, the objective of our program was to assess if the text message and peer support intervention is effective in reducing symptoms of anxiety, depression, and improving the overall well-being of participants compared with Eurocare after discharge from psychiatric inpatient treatment in Alberta. We hypothesized that the condition of depression, anxiety, and the well-being will be improved for the intervention groups at 6 months compared with the treatment in Eurogroup. So next, I will introduce the components of this innovation. The first one is a text for support service. Literature shows that the supportive text messaging demonstrates positive effects in terms of symptoms improvement and high inpatient satisfaction. It's a relatively low-cost, high-impact, and easily scalable program that uses existing technology, is devoid of geographic barriers, and is easily accessed to the end users. Our text message were designed by a group of very experienced psychiatrists, clinical therapists, as well as the professors from the psychiatry department in University of Alberta, based on the concept of CBT, provide through an online application site, Resilient and Hope. A bank of messages were generated and included different streams of message tailored for the several of mental health conditions, including depression, anxiety, bipolar disorder, general well-being, substance use, and personality disorder, and etc. So this is how it works. All of our researchers went to the hospitals in 10 sites in the Alberta province. So they'll go to talk with the nurse managers, and the nurse manager will provide them with a name list of patients who were about to be discharged within the next 7 days, and who they believe were most appropriate to get involved in the study research. Our researcher get the name list, and they'll go talk with these patients face to face. So the consenting participants will provide their numbers, their phone numbers, to our research team with their, and this number was added to a texting delivery platform, so they can receive the daily supportive message every day that focus on their primary mental health concerns. Here are some examples of this text message. First, like the general supportive message. Think of your recovery as an opportunity to find new solution in your life. And examples of message sent for depression. Monitor your mood and scale from 1 to 10, with 1 being lowest and 10 highest. Make a note of activities that improve your mood. And an example message sent for anxiety. For example, let's take a look of the second one. Rate how anxious each thing makes you. Do what makes you least anxious and work your way up. So for the last message, let's have a look. For the first part of this message, it helps our subscribers to identify the situation and be aware of their problems. And for the second part of this message, it encourages them to take actions, work out from things that put them down, and go find a positive way of living. So in 2022, our group conducted a study investigate the subscribers' opinion about receiving the supportive text message for over 6 weeks. We have in total 181 responses. The result indicated that 95% of the participants found that the text message are positive, 51% said supportive text message made them feel they are more in charge of managing their depression and anxiety conditions. 70% of them reported improved their overall mental well-being, and 65% reported enhanced their quality of life. No subscribers reported that the message made them feel bad or made them want to take negative actions towards themselves or others. And this is the second component of this innovation. This is a peer support service. So evidence indicated that peer support service has positive effects, including lower inpatient service use, better relationship with providers, and increased engagement. The peer support workers who are in recovery and have lived experience with mental illness played a central role in this study. Peer support worker activities included supportive face-to-face visits, interact phone calls, text, Zoom meetings with patients, advocacy, and also connecting patients with the supportive services and activities in their community. Individuals identified to be at risk of readmission to hospital will be offered mental health peer support. Remember what I said in my previous slide? The nurse managers will provide our researcher with a name list of those who identified that were being discharged within the 7 days and were most appropriate to participate in the study. They will also identify our researcher with those who believe were in high risk of readmission. So after consenting, we will pair our peer support workers with these patients who are at high risk of readmission. So peer support is actually rooted in the idea that people who share the same experience can offer help, empathy, validation, information, and hope for another person pursuing recovery. Evidence also shows that providing peer support is actually good for the peer support workers themselves because it can give them a feeling of competence and personal value. To avoid the potential peer support worker burnout risk, Each peer support workers were assigned a mental health therapist to provide support and mentorship, and psychiatrists were available to help where needed. Our primary measure was clinical change in likely depression. We used the PHQ-9 scale, likely anxiety, GAD-7 scale, and well-being, we used WHO-5 scale from baseline and across the follow-up time points, 6 weeks, 3 months, and 6 months. And the second measurement is prevalence and predictors of the 3 clinical conditions under study. And then I will talk about our project design. We applied a pragmatic step-wedged cluster randomized approach. This is such a long name, but actually it's not that complicated. So in a step-wedged study, the design is actually extended to each clusters, provides pre and post observations, and switch from control to intervention exposure, but not at the same time point. To help better understand this model, let's first take a look of the year 1. So Q1, Q2, Q3, and Q4, each represents 3 months in a year. As you can see, the green color means control group. So the first column represents that in the first 3 months of the first study year, participants from hospital in C1, C2, C3, and C4 units were all enrolled to the control group. Since the 4th month of the first year, which is yellow color, new recruitments from hospital in C1 units were assigned to text message only group, and the other 3 clusters units remained the same. And in the last 3 months of the year 1, which is the blue color, new recruitments from C1, hospitals were assigned to text message with or without peer support group. C2 and C3 hospitals participants were assigned to text message only group, and C4 hospitals remained in control. So by creating such a sophisticated design, the good thing is that, firstly, it's about the ethical benefits. Everyone can receive intervention eventually with this kind of design. And second benefits that it's about efficient use of the resource, allows for the intervention to be implemented gradually, which may require few resources at each single time point. And the last one is about the internal control. Each cluster serves as its own control before receiving the intervention, which can improve the ability to detect intervention's effect. Of course, there's no project design is perfect. With this kind of design, I have to say, one of the drawbacks is that it's take a longer study duration. Since the intervention is kind of rolled over multiple time points, the overall duration of the study can be longer, which might delay the result. The second one could be the complexity. It is more complex compared with most of the normal random control trials, and more sophisticated statistical methods. And the last one, it required a very close coordination between different departments, especially for large-scale study that carried out in a multiple sites like what we did with our project. So here's the data collection information. The recruitment period were between 2022 March 8th to 2024 February 29th. And the inclusion criteria were individuals who have been diagnosed with mental illness, were ready for discharge from an inpatient psychiatry unit, were older than 18 years old, had a mobile device, can read English text message, and can provide informed written consent. For the recruitment process, I will not repeat because I've already discussed about this in my previous slides. And we also have a follow-up session. The follow-up data collections were through the questionnaire sent to participants' mobile phone. Here's the data collection result. Total number of cases recruited, we got 1,132, And we have 454 of our patients in the treatment as Euro group, 554 in the text message group, 124 in the peer support group, and for those who complete the 6-week follow-up, we have in total 274, which made the response rate 24.2%. And for those who complete the 3 months follow-up, we have in total 202. The response rate was 17.8%. For those who complete the 6 months follow-up, we have 186, with a response rate of 16.4%. For those who completed any service, we have 374 of them. The response rate was 33%. So as you might notice, the number of follow-up completion are not that high. So we kind of have this intention to treat analysis where anybody that complete one-time follow-up points will carry over to the endpoint. Regarding the data analysis, for the primary measurement, we are going to use ANCOVA to evaluate the change in the mean score severity of mental health symptoms between baseline and the endpoint of the study. Regarding the second measurement, we'll use a descriptive analysis to indicate the prevalence of conditions at baseline and the endpoint of the study. And we'll use multiple variable regression analysis to find the risk factors of likely depression, likely anxiety, and poor well-being. So here we come to the results section. The results I presented today from our preliminary data analysis. Our team is currently working on the 6 months data analysis, which will provide the final result. I'm looking forward to share those with you guys in the near future. So here, when we conducted this study, we got in total 1,004 responses. The sample included 55% of female, 36 of respondents were younger than 25 years old, and most of our respondents, 62% were Caucasians, and 51% had a high school diploma, 59% were single, 53% were unemployed, and 41% lived with their family and friends. Regarding the prevalence of clinical conditions under study, 26% of our respondents had been diagnosed with depression previously by their doctor, and 37% of our respondents met the criteria for likely anxiety. 56% were evaluated with likely depression, and 48% met the criteria for poor well-being at the time before they will be discharged from the hospital. Regarding the risk factors of likely depression, ethnicity, primary mental health diagnosis, anxiety, and well-being at discharge independently predicted depression among respondents. Caucasians were more likely to present with symptoms of depression prior to discharge compared to most of the other ethnicities. Those who diagnosed with depression who were more likely to present with symptoms of depression than those with other diagnoses, which is quite intuitive. Anxiety as well as poor well-being at discharge were also significant predictors. As for the result of anxiety, ethnicity, education level, housing status, likely depression, and poor well-being at the discharge significantly predict the likely anxiety symptoms before leaving hospital. Indigenous people were more likely to experience anxiety symptoms compared with other ethnicities. Surprisingly, respondents with post-secondary education background were more likely to experience anxiety than those with less than high school education. People who rented accommodation were more likely to experience likely anxiety than those who owned their own house. And also poor well-being and likely depression symptoms were also significant predictors of anxiety symptoms before discharge. Regarding the prediction of poor well-being, respondents who met criteria for likely depression and anxiety before discharge were more likely to present with poor well-being prior to hospital discharge. That's all. Thank you very much, guys.